Good. It's great to have Jaco and his team here. Jaco is passionate about lab hematology, about all things hemostasis, transfusion. They are in the center of the country as a center of excellence in bleeding disorders. And it will be great to hear what you and Lariska have to say today. I'm going to hand over now. Let's enjoy with you. I hope it's a nice interactive session. It's clear that we have to, let you know what we think of everything. And I hope there's some questions or quizzes or something funny. And I hope we can guess the right answers when you teach us about this very interesting topic. So over to you, Jaco.
Thank you, Estelle. Thank you for the kind introduction. And once again, thank you for inviting us to participate on this forum. We're very privileged and excited to be part of the deep dive. I'm just going to stop sharing my video to preserve some bandwidth. There we go. So the topic of my talk for this afternoon is on cannabis and hematology, how getting baked can bomb or perhaps boost your blood. So you might be sitting there in the audience. I'm just waiting for my slide to advance, sorry. You might be sitting there in the audience as a hematologist wondering, but why do you actually need to know something about cannabis and hematology? So the American Society of Hematology actually summarized it nicely with an ASH Clinical News publication in August of this year entitled Growing Marijuana Use, excuse the pun, citing that with growing recreational and medicinal use of cannabis, patients are embracing this trend of using cannabis and related products. And hematologists should know a bit about the risks and the benefits of this class of products. So internationally, there's definitely an acknowledgement that we need to know something about cannabis and its effects on our craft. But locally, there are also new rules planned for especially medical cannabis in South Africa. So I don't know how many of you are involved with the or familiar with the country investment strategy. So in the latest draft of this document that was issued by the presidency in May of this year for public comment, cannabis is actually recognized as a legally and globally traded agricultural commodity. And considering South Africa's agricultural competitiveness profile, the country investment strategy concludes that cannabis grown and processed for medicinal use is the most viable competitive sales channel to pursue at an industrial scale, and that capabilities developed for medicinal production can be rapidly deployed to service recreational demand from either local or international markets. And the CIS proposes that the state enable the finalization of a common cannabis regulatory framework geared towards industrialization for export with a focus on the medicinal value chain. So the point is, it's coming, and our patients will probably have greater access to a panoply of medicinal products that are derived from cannabis, or also to recreational cannabis. So what are we talking about when we're talking about cannabis and the cannabinoids? So basically there are two categories of cannabinoids, the phytocannabinoids and the endocannabinoids. So the phytocannabinoids are a structurally diverse class of naturally occurring chemical compounds, and they are abundant in the viscous resins produced by the cannabis sativa plant, especially THC, which we'll get to in a minute, is abundant in this plant, and CBD is abundant in the resin produced by the cannabis indica variant. Endocannabinoids are endogenous substances capable of binding cannabinoid receptors and functionally activating them. And they consist of a large group of fatty acid-derived active compounds which are involved in diverse molecular activities. So the phytocannabinoids, there are many examples, but the two most important ones are delta-9 tetrahydrocannabinol, or THC, and cannabidiol, or CBD. And then there are others as well, cannabichromine, cannabigerol, tetrahydrocannabivarin, and cannabinol itself. They all have different affinities for the cannabinol 1 and 2 receptor. They can also interact with other receptors, notably the opioid and serotonin receptors and other G protein coupled receptors as well. The endocannabinoids, the most prominent examples would be AEA or anandamide, and this was the first endogenous ligand identified, and it was isolated from pig brain in 1992. This was followed by the discovery of 2-AG, which was isolated from canine gut a few years later. And there are others that are also important, rhodamine and arachidonyl chloroethylamide. You must excuse my pronunciation. I'm not a chemist, so sometimes one trips over some of these words. But anandamide and 2-AG are the two most studied endocannabinoids. So conceptually, very similarly to the leukotrienes and prostacyclins and other icosanoid metabolites, they are synthesized in cells on demand from precursors in the cell membrane. And then they typically bind with either the CB1 or the CB2 receptor. There are also several endocannabinoid-like molecules, but the affinity of these endocannabinoid-like molecules for the receptors is low, and their role is uncertain at this point. But there is, however, a growing interest to discover other potential endocannabinoid receptor ligands which can bind to the typical cannabinoid receptors or the newly recognized endocannabinoid receptors. So if you look at these ligands for the cannabinoid receptors and their specificities, you'll see that the different compounds, so THC, which is a prominent phytocannabinoid, is a partial agonist at the cannabinoid receptors, but the other endocannabinoids and cannabidiol have got different effects. So cannabidiol is an antagonist at the CB1 receptor, for instance, whereas the endocannabinoids all have different effects on these receptors, varying from full agonists to antagonist effects. So where do you find these receptors? So the CB1 receptor is primarily found in the central nervous system, the brain, spinal cord, etc., also in the lungs and muscles. But interestingly, and I did not know this, I must acknowledge I'm now reaching a level of honesty that borders on stupidity, but I did not know that you actually got endocannabinoid receptors in cells and tissues that we deal with in our field quite frequently. So the bone marrow and the immune system have got CB1 and CB2 receptors. And then there are also CB2 receptors found in the spleen. So the endocannabinoids in the central nervous system, at least, seem to have more of a role with retrograde signaling, where synthesis and release of the 2-AG and AEA compounds would retrogradely signal to the presynaptic neuron through these receptors, and their effects would then lead to the psychotropic effects of the drugs. The THC molecule, for instance, would also bind to these receptors, and that would be the most important pathway for the psychotropic effects. But the endocannabinoids seem to have a retrograde effect on the synapse. So the cannabinoid receptors themselves, the two of them actually are fairly similar. They've got 44% amino acid homology. CB1R is highly conserved in vertebrates. It's also found in some invertebrates, and it seems to have some conservation across vertebrates that actually is quite profound, with 99% and 97% amino acid homology between rat and human CB1R receptors respectively. The CB2R receptor shows a bit less interspecies homology, with only being 82% identical between human and murine receptors. And as I've mentioned, the CB1R receptor is abundantly expressed in the neurons of the brain and central nervous system. CB2R, as we've mentioned, is localized in immune cells and organs. So these are tissues that and cells that hematologists would be familiar with: mononuclear cells, mast cells, NK cells, the spleen, thymus, and lymph nodes. And in mammals specifically, the CB2R receptor is present also in hematopoietic cells. So how do these receptors signal? So some of you in the audience preparing for an FC Path Part 1 exam might recognize all these downstream signaling molecules. So the CB receptor 1 is conveys its intracellular message via G protein coupled receptor mechanism, but its main effect is to block adenyl cyclase and to decrease the amounts and concentrations of cyclic AMP intracellularly, and this is purported to be responsible for the psychotropic effects of the phytocannabinoids, so the euphoria, the relief of anxiety, the anti-nausea effects, the anti-anorexic effects, etc. But it also has a host of other downstream signaling pathway effects. So some of you might recognize these PI3K and MAP kinase messengers that are activated, and also some of these other ceramide-related pathways that are activated as well. The CB2 receptor uses a similar mechanism, also a G protein coupled receptor with a few other downstream messenger molecules, but again, a very prominent effect is this reduction in cyclic AMP. So what does it actually do in blood cell development? So as we've mentioned, the cannabinoid system is also involved in hematopoietic cell development. So these receptors are expressed in different blood cells, so macrophages, erythrocytes, megakaryocytes, platelets, mast cells, B cells, and T cells. So in vitro studies have shown that anandamide, so the endocannabinoid anandamide, can actually stimulate hematopoiesis through activation of the cannabinoid receptors. And interestingly, the subtype 2, the cannabinoid 2 receptor, is expressed in blasts from AML patients, but not in normal myeloid cells. And bone marrow stromal cells actually release large amounts of endocannabinoids, which either alone or with growth factors exert diverse effects on hematopoietic stem cell development. A few examples would be clonal cell expansion achieved via activation of the CB2 receptor, and then in a megakaryocytic or megakaryoblast cell line model, evidence of a functional role for 2-AG has also been shown in megakaryocyte maturation and platelet production. 2-AG can also cause hematopoietic cell migration via the CB2 receptor, and this indicates that 2-AG is probably important in immune cell mobilization. Verotamine is an interesting endocannabinoid in that it is a stimulator of the megakaryocyte. It can stimulate megakaryocytic differentiation and maturation, as well as mature platelet production from mature megakaryocytes. And interestingly, it can also induce platelet aggregation in blood and in platelet-rich plasma, but the molecular mechanism for this is not defined yet. So the point is that the cannabinoids are actually can play actually quite an important role in blood cell development, but also in the function of more mature blood cells. So what are the effects of the cannabinoids on more mature blood cells and their function? So if we firstly look at erythrocytes, the cannabinoids, particularly anandamide, can trigger apoptosis of nucleated cells and erythrocyte eryptosis. And this is mediated through cyclooxygenase-dependent formation of prostaglandin, which activates calcium channels, leading to the entry of calcium with water loss and cell shrinkage. And very interestingly, it has also been reported to induce cell death and decrease parasite burdens from human erythrocytes infected with Plasmodium falciparum. So in an interesting study from a group from Cape Town, they could demonstrate that THC shows activity against cultured Plasmodium falciparum. Very interesting. And this was actually already known for years in the Chinese pharmacopoeia, that THC could inhibit malarial parasite growth. So the Chinese pharmacopoeia is the world's oldest pharmacopoeia, and it describes the use of cannabis for malaria fever for thousands of years already. So the Sosa et al. From Cape Town was able to show that THC could inhibit the malarial parasite growth, but that CBD, which was also tested, showed only mild anti-malarial activity. THC and CBD can also actually increase whole blood viscosity and affect erythrocyte elasticity by increasing erythrocyte elasticity, but it has an adverse effect on membrane integrity. shown in this study shown here, which was published in the Journal of Cannabis Research. So not only is there an entire journal dedicated to cannabis research, it also has some hematology content in it. So you might be sitting there and saying, well, but hold on, I know of a condition in hematology where red cell elasticity and whole blood viscosity is quite an important concept and quite an important issue. Sickle cell disease. So sickle cell disease, also being a very painful condition, sort of lends itself to the use of cannabis, marijuana, and cannabinoids. And this prompted a review of all the studies that have been done on the use of marijuana for pain relief in adults with sickle cell disease, which had some quite interesting findings. So as you can see, there are a number of studies that looked at this, but I want to just point out a few here that were reviewed by these authors. And the first one that I just want to point out is this study by Abrams and others, which you'll see is actually the only randomized controlled trial on the use of marijuana in sickle cell disease. And they looked at the effectiveness of inhaled cannabis compared to inhaled placebo, and found that while inhaled cannabis was safe and more effective in elevating mood and the general sort of well-being of the patients, there was no remarkable difference in pain when comparing placebo and cannabis. Another study that's important is the one down here that I just want to highlight, the 2017 retrospective study that looked at whether patients with sickle cell disease using cannabis had fewer acute veno-occlusive crises that required hospitalization. But the data actually suggested that the frequency of veno-occlusive crises increased with cannabis use in sickle cell disease patients rather than in non-users of marijuana. Another important study is this one at the bottom here by Kalu et al., where they looked at whether hydroxyurea or marijuana use had a more pronounced influence on pain. And they could find that although over half the patients surveyed in this questionnaire-based survey admitted to using marijuana, over 80% of them stated that the marijuana was not as effective as hydroxyurea in managing their sickle cell disease related pain. And this is sort of a running theme where some of these studies would show possible benefit, especially in terms of the psychological effects of the pain, whereas others would not. So the authors of this review concluded that based on the literature assessed, marijuana use in sickle cell disease patients either worsened their painful crises or offered little to no help compared to opioids or hydroxyurea usage. There are, however, only limited randomized controlled trials on this, and further data would be required to address whether cannabis use is efficacious for pain relief in patients with sickle cell disease. So what about the effects of cannabinoids on the immune cells, which seems to actually be quite an important thing? So B lymphocytes express the highest numbers of the CB2 receptors amongst all the blood cells, and when they are activated by various insults and stimuli, they actually increase their CB2R expression. And cannabinoids can control immune cell recruitment and chemotaxis to sites of infection and injury, particularly 2-AG is chemotactic for B lymphocytes. Conversely, CB2R agonists, like these two synthetic compounds shown here, actually inhibit chemotaxis of T cells. So it seems that THC in particular is immunosuppressive and affects the splenic T cell response, and also suppresses T cell proliferation and the release of a whole bunch of cytokines. So it looks like, at least in terms of B cells, the cannabinoids might be pro-inflammatory, whereas with T cells, they might be a bit anti-inflammatory. But there's still some research that needs to be done here. So if you look at the effects of the endocannabinoids on the cells of innate immunity, you would see that especially anandamide has got quite a number of anti-inflammatory effects. 2-AG also has some anti-inflammatory effects, but if you look at their pro-inflammatory effects, it does seem like that 2-AG has got some pro-inflammatory effects on the innate immune system as well. Whereas with the adaptive immune system, it seems as if the bulk of these effects of the endocannabinoids, at least, now we're not talking about the phytocannabinoids like THC, but the endocannabinoids at least seem to have a more anti-inflammatory effect than a pro-inflammatory effect. So you might have now sat there thinking, but I know of conditions in hematology where immunosuppression and anti-inflammatory effects are quite important. So what about graft versus host disease? So already back in 2011, these guys here postulated that targeting cannabinoid receptors could be a novel treatment approach for graft versus host disease, and tested this in an experimental murine model and found that the phytocannabinoid THC is effective for treating graft versus host disease in the semi-allogeneic model. And a few years later, these researchers from Israel looked at CBD, whether CBD could be beneficial for graft versus host disease prophylaxis, and found that it could be in this phase 2 study. So whether these possible effects of the cannabinoids in stem cell transplantation represent high hopes or reefer madness is still open for debate, but it does seem that there might be something to it. What about the effects of cannabinoids on platelet function? So we've already mentioned a little bit about the effects of the endocannabinoids, anandamide, etc., which can activate platelets and increase intracellular calcium. But the phytocannabinoid THC, which has been identified as a potential risk factor for thromboembolism, can actually also initiate abnormal platelet activation through the increased expression of the platelet receptor GP2B3A and P-selectin. In fact, the endocannabinoid T2AG is quite abundant in platelets, which suggests a possible physiological role during platelet activation and has been shown to enhance the binding of serotonin to platelets. Platelets also produce endocannabinoids, as I've mentioned, conceptually very similar to the production of prostaglandins and prostacyclins, leukotrienes, etc. And platelet activating factor can stimulate platelets to produce even more 2AG. LPS, lipopolysaccharide, which, as you know, is a key component of endotoxic shock, also increases anandamide levels. And for the lab guys among us, there's also an important pre-analytical consideration where the production and release of anandamide may actually complicate endocannabinoid measurements in blood, where this ex vivo release of anandamide can confound measurements. So just something to keep in mind. What about the other relevant effects of cannabinoids? So they can have quite a range of effects on the endothelium and the bone and bone marrow microenvironment. So the endothelium is a source of endocannabinoids, but also a source of endocannabinoid metabolism. Activation of cannabinoid receptors in a murine aorta, for instance, has shown to decrease expression of various adhesion molecules. The cannabinoids also modulate matrix metalloprotein 9 production in multiple cell lines. Anandamide, derived from cultured endothelial cells when stimulated with estrogens, reduces the release of serotonin from ADP-stimulated platelets, and this has been postulated by some to be the basis, or at least a partial explanation, for some of the vascular effects of estrogens that actually has to do with the endocannabinoid pathways. And it's this balance between the release of thrombogenic endocannabinoids and their endothelium-dependent metabolism, which likely determines their role in thrombosis and is probably altered in disease states like atherosclerosis. So just to sort of put everything together here and looking at the established and putative interactions between cannabinoids, platelets, and the endothelium, you can appreciate, as I've mentioned, that even the phytocannabinoids, not just the endocannabinoids, but the phytocannabinoids like THC, with its ability to increase the expression of GP2B3A, can have a significant effect on platelet function. The endocannabinoids then has a whole host of other effects where the metabolites can influence platelet activation. They can make platelets more sensitive to serotonin and stimulate the release of serotonin. And as we've already mentioned, endotoxins have been shown to stimulate the production of 2-AG, which can then also further activate platelets. So when we're talking about the cannabinoids and their effects on atherosclerosis, cannabis smoking has been identified in earlier studies. So this determinants of myocardial infarction study estimated a 4.8-fold increased risk in the 60 minutes after the use of marijuana as a risk factor for initiating myocardial infarction. And this is probably due to the acute cardiovascular effects of cannabis smoking, which are seem to be not insubstantial, like tachycardia, hypertension, and orthostatic hypotension. And in a very old study, cannabis, when compared to placebo controls, was found to provoke symptoms in patients with stable angina, most likely due to these effects mentioned here. But larger scale subsequent trials, which when correcting for diet, alcohol, and tobacco smoking, found that despite the association of acute cannabis use with an increased risk of MI, long-term cannabis smoking was not associated with an increased cardiovascular risk. And they concluded that cannabis was not an independent risk factor for cardiovascular disease, but was associated with a generally unhealthy lifestyle. So low doses of THC acting via the type 2 cannabinoid receptors caused a decrease in the development of atherosclerotic plaques in murine atherogenesis models. So the plot thickens. It appears that low-dose THC might actually be beneficial. And this seems to be due to suppression of macrophage chemotaxis and macrophage activity. Also, low PEA levels, so the endocannabinoid PEA, will protect LDL against oxidation, which, as you know, is a feature of atherogenesis. So low PEA levels protects against atherogenesis, whereas high concentrations appears to promote oxidation. So really not that well sorted out yet whether the endocannabinoids are good or bad in the context of atherosclerosis. What about the effects on the bone and the bone marrow microenvironment? So interestingly, bone cells, so osteocytes, osteoblasts, etc., would express both the receptors. And the endocannabinoids can regulate migration, differentiation, maintenance, and survival of these cells. And activation is also important in osteogenic differentiation of bone marrow mesenchymal stem cells. So really, it seems like the system has fingers in multiple pies. So if you want to try and sort of just summarize everything here, if we look at the therapeutic effects of the phytocannabinoids and endocannabinoids, you'll see that they've got quite a prominent effect on megakaryocytes, T cells, macrophages, and dendritic cells. And in our world, this has an effect on megakaryocyte maturation, platelet activation, and osteogenic differentiation. And if you look at the effects of the distinct endocannabinoids and the distinct phytocannabinoids, rhodamine, as I've mentioned, implicated in megakaryocyte maturation, also has shown to be able to aggregate platelets in blood and platelet-rich plasma. And whereas the 2-AG, the endocannabinoid 2-AG, is implicated in inflammation and megakaryocyte maturation. And anandamide is important for erythrocyte survival and also has a role in inflammation. The phytocannabinoids THC and CBD seem to possibly have an effect on the pathophysiology of graft versus host disease, with some limited evidence to show that these compounds could be beneficial in these patients. So now with some pot in every kitchen and all our patients being on some form of medication, what about the cannabinoids and their drug interactions? And this is an important concept. So just for some background, the phytocannabinoids THC, CBD, and CBN are extensively metabolized by the cytochrome P450 enzyme system in the liver and intestines. and their biotransformation is chiefly driven by CYP2C9 and CYP3A4. So many of you will recognize these as important enzymes for the biotransformation of lots of the drugs that are used in hematology on a daily basis. And in addition, CBD may also undergo direct conjugation via the glucuronidyltransferase system. So the point is here that several drugs can affect cannabinoid metabolism, and the cannabinoids can affect the metabolism of several drugs. So the CYP3A4 inhibitors, which are mentioned frequently, would be things that we know, like itaconazole, the macrolide antibiotics, augmentin, but importantly also imatinib. And this has been shown to actually be able to double the concentration of THC and CBD if this is given concurrently. And when starting to read around this topic, I was reminded of one of our patients in one of the peripheral national coverage hematology clinics years ago when I was a registrar, who was on imatinib 600 milligrams daily. And he confided in us that he had been using recreational cannabis, but then said ever since he was put on imatinib for his CML, that the effects of the cannabis really took hold of him in a dramatic way. And it's difficult to translate it out of Afrikaans, but basically it took him to town. And he was quite worried about his now the effect of the imatinib that he's now taking, which now boosts his recreational marijuana's effects on his system. But also CYP2C9 inhibitors can influence the increase in the concentrations of THC and its effects, importantly. So as our good friend Naas Boot, I would say, but on the other hand, there's also the flip side of this coin. On the other hand, Darren, the cannabinoids can actually then influence the drugs that we give to patients and the effects of the drugs that we give to patients. So CBD, for instance, which inhibits the CYP2C9 system, can increase bleeding with warfarin being metabolized by the CYP2C9 enzyme. So this CBD and its active metabolite has got no activity on the drug transporters. However, an inactive hydroxylated metabolite of CBD, this 7-COOH-CBD, is also the most abundant metabolite of it, can be a substrate for the P-glycoprotein transporter, and can also inhibit breast cancer resistance protein. And substrates for this protein would be things that you would use frequently, imatinib and methotrexate, and you can then get increased side effects from these substrates. So both the active drugs as well as their metabolites can have an effect here. The general recommendation would be obviously to avoid co-administration and to monitor for toxicity and to reduce the substrate of the dose whenever possible, the substrate dose whenever possible. So what are we talking about here in terms of these, the products that are available? So this is just one table showing some of the products that are available. And I suspect that this will absolutely explode in the next few years in terms of the products that will be available fairly over the counter, other herbal extracts and oils. So many of these products that you will see here are natural extracts and extracts of CBD, and it's actually only the top two here that are FDA approved. So dronabinol has FDA approval as an anti-cancer drug for induced nausea and vomiting, and nabilone for the same indication. But dronabinol also has an additional approval for AIDS-related anorexia. So apart from these two products that are FDA approved, which are both synthetic THC or synthetic derivatives of THC, there are many other compounds that vary in their concentrations and ratios of THC and CBD with various different usages. So this then brings us to what are the potential interactions with other drugs used in hematology. So just to show you here, if you look at the drug transporters and cytochrome P450, THC, CBD, and CBN are substrates for various cytochrome P450 enzyme systems, as I've shown, and can also inhibit many of these drug transporters. Now, to show you how important this could potentially be, if you look at this list of drugs, and these are all drugs that many of you might frequently be using, so methotrexate. Here we can see all the tyrosine kinase inhibitors, which are transported by the P-glycoprotein, for instance, and metabolized by the CYP3A4 system here. You can understand that there could be many potential drug interactions between things like the tyrosine kinase inhibitors and all these cannabinoids, especially the phytocannabinoids. And it's also true for things that you might use in your practice to treat acute leukemia, for instance, here's daunorubicin, doxorubicin, etc. It's transport by the P-glycoprotein system, which can be influenced by some of these CBD metabolites. Then the last question, and this was also interesting to me, is whether to inhale or not to inhale these products. So apart obviously from the COPD, the chronic bronchitis and the asthma risks that are associated with smoking marijuana, immunocompromised patients, such as patients receiving induction chemotherapy, also have a risk for developing fungal infections and pneumonia, especially aspergillosis. So the fungal spores can grow on the plant and are actually not easily killed. And patients using cannabis have a 3.5 times more likely risk to develop fungal infection than those who do not. But inhalation forms like vaporization may provide better control over the onset, depth, and duration of the therapeutic effect. So remember, many of these patients would use this for pain management, would use this for nausea and vomiting, would use this for chemotherapy-associated anorexia, etc. So if you use some of these vapor compounds, of which there are many, the inhaled peak plasma concentration is reached in 2.5 minutes and dissipates fairly quickly, whereas oral THC takes 2.5 hours to reach a much lower peak and is metabolized by the liver and can potentially have an increased psychoactive effect then. So just to conclude my part here, the cannabinoids have important interactions with the hematological system, which I must admit I was completely unaware of. I did not realize that the endocannabinoid system and its other interactions with phytocannabinoids are so important in the physiology of the hematological system. And they can have potentially beneficial effects. We're thinking here about some of the pro-hemostatic effects, for instance, and particularly the anti-inflammatory effects of the cannabinoids. But they could also be harmful. And these would be the prothrombotic effects and especially the multiple drug interactions which could ensue with the use of these products. So obviously more research is required on the potential applications and dangers in hematology. And I think this is probably now more of an issue, and going forward it will become more of an issue as patients have greater access to these compounds, and also more local, international, and society or association guidelines probably need to be drafted in order to standardize cannabis use, and also to help physicians to manage the potential conundrums which are sure to arise with more wider use of these products. So with that, I'd be happy to take any questions or comments from those that are still awake. Thank you.
Jaco, excuse me, sorry for the echo. Are you there?
Yes, I'm here. I can hear you.
Can you hear me?
Yes.
Okay, great. As you know, I'm busy with two computers here. I must just actually get rid of the one. I always wonder why, after all these years, we are still having all these components that's not tamed into, that still is going to develop. Do you know why that is? You would think by now it's all figured out.
Yeah, I suppose every generation in medicine would think that they've got it all figured out. And the longer you are in it, the more you would realize that there's still so much more to be learned. And I was just really quite surprised to see the proposed roles, but also the established roles for this system in hematology. I was really quite surprised. And I think as a big problem with this was the whole system, the endocannabinoids and the phytocannabinoids, was sort of shrouded it was shrouded in the fact that the use of marijuana was not legal. So I think a lot of research on it was lagging behind because there was other things that would be less frowned upon to do research on. And I think now people are starting to realize that this system could be potentially quite important. But yeah, I think we will probably never get to a point where we know absolutely everything about the physiology of the hematopoietic system and hematology. We will probably always have additional pathways identified, additional receptor systems, additional metabolic pathways, etc.
And human beings will always want to take a pill or a drug or something. I see Vanitha has a very interesting question, which I can't answer. Let's see. But just one thing about the phytocannabinoids. We have had a lovely young man that was sent to us from Pretoria with a plastic anemia that actually was a Fanconi. He turned leukemic. But the fact is that he is actually well known because him and his wife travel up into Africa. They're amazing. They're completely amazing. So he was cured with his transplant for his leukemic Fanconi, and they actually repainted the rooms in our transplant unit as part of all the wonderful things they do. But even though we started him on Jacob, he had very bad GVHD. He will always say, and he's spoken to talk shows, and he's very, otherwise I would not be talking about his experience, but he would say it's the cannabis oil. And I was like, always, my goodness, you were on he was the first patient we put onto Yakawi. That was the first time we could use it, and when it came known. And I thought, wow, it was probably that actually cured or took you out of this terrible. And he kept saying it is the CBD. And he actually also, I think, grows his own. And now you see that, I was probably wrong in my assumption that he just felt better. It seems to have really, really made a difference for him. And it may really have been the thing that made, I think I'll really have to go and think about it again as a transplanter. So that's just it was very good for me to see that. So
yeah, no, that's interesting.
Yeah.
Sure, Estelle, that's very interesting. I must say, when I saw that murine model and then the later publication on using it possibly as prophylaxis in graft versus host disease, I was stunned. It was really interesting to see. And then when you read also the ASH clinical news excerpt that I showed in the beginning, they do have some quotes where they interview transplant physicians and other physicians in the States, where some of them have said they have tried it. They've given it to their patients, and they have had mixed results. Some of them could say that they could see some benefit, but others did not. But there were definitely some that said they tried it in their practice and they could see benefit. So very, very interesting. And I think there's probably room in the next few years, with the sort of legal and legislative environment changing, for more of these studies to see whether there's actually hard randomized controlled trial data for use of these compounds. So yes, and we'll have to see. You said there was a question from From
Vanitha
Philip.
has a talk.
Yes.
It's very interesting. You're going to get these interesting questions, Jaco.
Yeah, so you said, Barra, you noticed refractory aplastic anemia in cannabis users. Yeah, that's interesting. You know, one would actually thought that perhaps you would have thought that perhaps in someone with aplastic anemia, because of the possible immunosuppressive effects, that you could actually see, you know, actually that it could be potentially beneficial even in aplastic anemia. But I think the main thing is here, we must distinguish between the effects of the phytocannabinoids and the endocannabinoids. So the phytocannabinoids can have some different effects on the cells of the immune system. And I would suspect here that in this case, perhaps there was actually some more pro-inflammatory effects from the phytocannabinoids in these patients, which could explain why you've seen this particularly refractory aplastic anemia cases. But look, this would all be speculation. I think it's early days, and there would be more clinical trial data needed to actually say anything more at this point. Yeah, and then Susan Lowe is asking whether we've come across any information regarding the medicinal effect of magic mushrooms, asking for a friend. Susan, no, unfortunately, I didn't come across any effects, medicinal effects of magic mushrooms. But I will find out for you, for your friend. I'll find out for your friend, and then we'll let you know. And then Stephanie has a comment here on the NEJM in 2018, where a case series of more than 150 patients was reported who presented with mysterious coagulopathy associated with cannabinoid use. Turns out it was due to superwarfarin toxicity added to potentially prolong the effect of DAGA. Yeah, so that's and this was inhaled. Yeah, that's very interesting, Stephanie. So, and I think you can probably tie this back to the effects on the CYP2C9 enzyme, where you could have a potential effect like that. I think it might have something to do with that, but very interesting. And I think also the point is, yeah, there's a lot about this this endocannabinoid system and its interactions with the hematological system that we don't know about. Thank you.
Just from my side, drug users sometimes do have aplastic anemia, as we know, and nobody really knows what it could be. But, you know, we've now got we've got the patients that Vanitha speak of, as well as Stephanie's mention. And it seems to be the mix that people, you know, whatever they do with it. And isn't that the biggest problem for me, is what some cannabis oil products or CBD or whatever, I'm getting confused, but some of them are very pure, very strong, very effective. Others there's almost nothing in them. And then maybe filled up with superwarfarins, whatever.
Yeah, no, that's interesting. I mean, we also hear stories sometimes about patients mixing their ARVs, for instance, with DAGA and then smoking it. And this is an interesting case report or case series that Stephanie highlights here with, you know, this was a superwarfarin toxicity with warfarin added to potentially prolong the effect of the DAGA, and then you actually then end up actually prolonging the effect of the warfarin more than you would of the DAGA. And I'm always reminded of that patient we saw at one of our outreach clinics, who just said that he was always a smoker of marijuana and it just sort of chilled him out. But then when he was started on imatinib 600 milligrams, the effect of the marijuana, and he made a particular point of it to emphasize to us that he did not change suppliers, so that it was not the DAGA to be blamed, but the imatinib. And since he started taking the imatinib, the DAGA really took him to town. So I think probably in hematology, that's where we will see most of the effects as more patients start to use recreational marijuana more comfortably, and also start to use all of these oils and inhalation vapors and other extracts and things more openly. And once they've got more open access to it in a regular market economy, that we will see really interactions with well, drug interactions being the most prominent thing we have to deal with. So yeah, so thank you everybody for listening to my talk on this. If there are any other questions that you might think of later, you're welcome to send me an email and I'll have a look. I'm not sure whether I'll have the answers. This was also a very new topic to me. And I just thought of it, just to give you some background why I thought of actually talking about this is the Dean actually mentioned to us where this was raised in the strategy that I mentioned earlier in the talk, and that the university might actually at some point be asked for sort of an opinion on the medicinal uses of cannabis and all the related compounds. And it started me thinking, because I absolutely knew nothing about it and started to read up about it. And then I saw, but sure, in hematology, it's actually, there's actually quite a lot surrounding it. So I hope I could have just sort of primed and piqued your interest a bit into the topic, and perhaps I could help you with one or two patients in the future. So yeah, if there are no other questions now, I think if it's okay with Estelle, then perhaps we can move on to the next speaker. Is that okay with you?
Absolutely, yeah. Let's
Okay.
go. I'll post the link just now.
Great, thank you, Estelle. So if you don't mind, then I'm somewhat going to go ahead and introduce Larissa, which I think many of you also know very well. Larissa Haupt is one of my friends and colleagues here in Bloemfontein. So she's a hematologist here at Universitas Academic Hospital. She, let me just quickly stop share. Yeah, okay, there's Larissa's already sharing a screen. So yeah, she's a hematologist here at NHLS in Universitas in Bloemfontein. She's a Free Stater with obtaining her undergraduate MBCHB and her FC Path and MEd Hem cum laude here at the UFS. And she's involved in laboratory diagnostics and research, and is a UFS lecturer for undergraduate and postgraduate students. And she has a special interest in hemostasis and runs the bleeding and thrombosis clinic here at Universitas for the adults, but also consults for the pediatric hemophilia clinic at Universitas Academic Hospital. So it gives me great pleasure to hand over to Larissa, who's going to be talking to us about cigarette smoking, and where there's smoke, there's fire. Thank you, Larissa. We're looking forward to your talk.
Right. Good afternoon. Jaco, can you hear me? And are my slides advancing?
Yes, we can hear you, and your slides are advancing. Thank you.
Good afternoon, everybody. Thanks, Estelle, for giving us a bit of a soapbox to say one or two things about substantial substances. I am by all means just a sideshow to Jaco's great lecture that he just gave on cannabis. We were kind of up in airs whether we're going to do smoking or alcohol, and we ended up deciding on smoking. So the aim of my probably 15-minute overview of how smoking affects the hematological system is just to explain how it's not just the regular polycythemia, hypoxia-induced polycythemia that we so often associate with chronic smoking. It's a bit more than that. And also, we tend to, well, everyone knows smoking is bad for you, but we tend to think of the common things. We tend to think of lung cancer and COPD, and basically the lung-associated things. But smoking is by far more complex than just the effects on the lung. So let's have a look at how it affects the hematological system. So your approach to any effects on the hematological system should try and include the three main cell lines. And we are going to follow that same approach today. We'll look at the white blood cells, specifically the immune function, malignancy associated with smoking, and then also non-malignant disorders. We'll look at red blood cells, and we'll look at the effects on platelets and the coagulation system in general. So starting off with by far the most abundant cell in the peripheral blood, the red blood cells. I'd like to kick off with these two tables. So these are both studies done quite recently, comparing the hematological parameters between smokers and non-smokers. So first off, on the left-hand, my left-hand side, is this comparison done by Parametraler, which compared 95 non-smokers and 55 smokers. And I have circled the significant differences for you in red, and then a second comparison between 100 smokers and 100 non-smokers and 56 smokers. And they defined it at least 10 or 20 cigarettes for 3 years. This first review or experiment did not really specify what they assumed to be a smoker. But as expected, the parameters most often affected in the red cells, at least, is the HB. In this study, the hematocrit was significantly affected, but not on the left-hand side. The MCV and the MCH also affected, similarly here. And interestingly, the red cell distribution in smokers is actually tighter than the red cell distribution with the non-smokers, which I can't really explain. I wonder if anyone in the audience would like to contribute to that at the end of the lecture. But probably the most substantial change that we see clinically as well is the change in hematocrit with higher hematocrit seen in the smoking population. And that is probably the most common association of smoking in the hematological system that we can come up with. And interestingly enough, it's not just hypoxia induced. So it's not just following long-term lung damage and hypoxia, but also the exposure to carbon monoxide, and something else that I'm just going to leave open and we'll discuss in a few minutes. But it's not just, like I said, the expansion of the red cell volume. And there's also a relative decrease in the plasma volume, and these two contribute together to increase the hematocrit. Usually, it is accompanied by an increased EPO level, at least to some extent. And this is also, it has a very tight relationship with the degree of smoking. And then I'm going to put my foot in it and talk about Guy's-Box syndrome, which is something that I last thought about when I was writing my finals. But it is a very controversial syndrome, and to some specialists and some teachers of mine was considered to be a non-issue and a non-thing. Originally described in 1905, Guy's-Box described males with hypertension, anxiety and depression, generally being quite overweight and with a stocky appearance and mainly central obesity. Most of them had a smoking habit, and these were the main symptoms, followed by basically symptoms of symptomatic polycythemia with headaches, vascular diseases, stroke, acute arterial occlusion, etc. And the pathophysiology was never well understood, and basically thought to be due to a decrease in plasma volume, as these patients usually had normal EPO levels. Synonyms were stress polycythemia due to the association with anxiety and depression, relative polycythemia due to the belief that it was due to a decrease in plasma volume, and then my favorite was polycythemia hypertonica because of its association with hypertension. So, as I've mentioned, very controversial, thought to be a non-thing, but bringing me to this very recent publication in February of this year, and it's actually not available online yet, so I've literally had to get it somewhere non-official, but it's from Nature, so a very reputable journal, where it says polycythemia hypertonica revisited, a metabolic syndrome with high renin hypertension. So basically, if you look at this figure, Guy's-Box introduced this term polycythemia hypertonica, and he obviously described a lot of clinical features that hold some familiar overlap with what we now know to be metabolic syndrome, which was not described in full when he described Geisbach syndrome. And we now better understand hypertension in general, and we also now understand metabolic syndrome better. And this article actually proposes that these two are linked. The RAS activation and the reason why angiotensin and ACE inhibitors work so well for hypertension is due to this activation of this axis. And when inhibiting this, we inhibit hypertension. But there's also more than enough evidence to suggest that angiotensin 2 also increases the red cell mass in producing polycythemia. But due to a large percentage of these patients that we now know have metabolic syndromes, a lot of them also have hypertension, and we are putting them on these ACE inhibiting drugs, and therefore they are not getting polycythemia. So I'd like to just read this excerpt from this article. The reason of scarcity of polycythemia in our days and the disappearance of Geisbach syndrome despite a rise in the prevalence of metabolic syndrome may emanate from the fact that the RAS inhibitors we are widely using are actually lowering or normalizing the hematocrit values in many patients who would otherwise be expected to suffer from polycythemia. And in converse with the suspected polycythemia that we used to see in Geisbach syndrome, we are now actually seeing a lot of anemia in patients chronically on ACE inhibitors, and a lot of publications and interest in why these patients are anemic. The whole inflammation versus iron deficiency axis is being heavily studied in this group of patients, and this just is some food for thought. And Geisbach is probably not disappeared. We are just actively treating it. Moving on to the white blood cells, divided into the immune function, how cigarette smoking affects white blood cell malignancies, and also discussing one non-malignant disorder. So the fact that smoking influenced the immune function is also depicted in, if you just allow me to go back into these comparisons between the full blood count in smokers and non-smokers, where you can see that the leukocyte count is also statistically increased in smokers, and in many other publications as well as in this gray table, you can see that the neutrophils and lymphocytes are also somewhat increased compared to non-smokers. So you would actually suspect that there should be an increased immune function in smokers, but that is unfortunately not what we see. So even though we do see some entire subsets of lymphocytes increased in smokers, these subsets express pro-inflammatory as well as immunosuppressive molecular markers that are not expressed in non-smokers, and this leads to an overall decrease in immune function. So it's definitely more functional deficit and not really a deficit in numbers. Interestingly enough, again, in a very reputable publication, they do note by subset analysis that smoking suppresses the immune function, but maybe this is a good thing. So there are quite a lot of publications listing that smoking actually has a protective effect in some autoimmune disorders and neurodegenerative disorders. And this was also found in this very recent publication where CD25 expressing T cells, which we know are T regulatory cells, are increased in smokers. And this probably, we can link these two between autoimmune disorders being, smoking actually being a protective effect in autoimmune disorders. Then lastly, just to again state the fact that it's definitely not just a lab-derived conclusion. Smokers definitely have a higher risk of invasive pneumococcal disease, a 7-fold higher risk of influenza, and also contracting serious influenza needing hospitalization. And then in our setting, something that we should definitely be aware of is a very high risk seen in TB. This was not really deduced to a numbered or increased risk, but TB is much more common in smokers than non-smokers. Then moving on to white blood cell malignancies, For at least 3 or 4 decades, it's been well known that smoking is a risk factor to develop AML and MDS. And these two very well-written meta-analysis also compare some studies and trials and population data to this effect. And in 2014, these authors calculated a 40% and 25% increased risk of AML in current and former smokers, respectively, compared to non-smokers. So it does look like your risk does decrease after cessation of smoking, but it doesn't disappear completely. In 2018, a similarly designed meta-analysis looked at this again, and they found exactly the same number, which I found interesting, 40% for current smokers and a 66% increase for ever smokers compared to non-smokers. And for the physicians, they defined ever smokers as patients having at least 30 pack years of smoking history. So undisputed that smoking definitely is a standalone risk factor for developing AML and MDS. Also, just to display it in a figure, you can see here that this was a comparison between 2 decades in these listed countries, and they compared age standardized dailies, which is disability adjusted life years. The turquoise is smoking, the blue is occupational exposure to benzene, which we know is another very well-established risk factor for development AML. And then the other one was high body mass index, which was very interesting, which I wasn't aware of. And you can see that smoking is by far the front runner as a risk factor for these increased dailies. And I'm happy to see that there is some decrease in the later decade, but still substantial risk in these populations. Something else I came across that I just found interesting, if there are any pediatric oncologists in the audience, is there's been an interest to see whether smoking during pregnancy might have an increased risk of childhood cancer. And interestingly enough, that was shown to not be a thing. However, paternal smoking before conception and during pregnancy is associated with an increased risk of childhood ALL. And this brings one to think it's probably then something that happens to the sperm before conception, and that this genetic trait is then transferred in that way, and that this is not an issue for women before conception. So I found that quite interesting. Right, what about non-AML? I've mentioned that it's well established, but there are some other cancers that are more common in smokers. So non-Hodgkin's lymphomas, the InterLymph study published in this section of the InterLymph study published in 2005 showed a 45% higher risk of developing follicular lymphoma compared to non-smokers. And this risk was dose dependent, with increasing risk in heavy smokers, which they defined as more than 36 pack years. So it doesn't seem, according to the InterLymph study, that this was statistically significant in other non-Hodgkin lymphomas. However, in 2014, Slager et al. Published an increased risk, hour of 0.9 in smokers compared to non-smokers who develop CLL, which is the most common leukemia in the Western world. So substantial increased risk there. If we look at non-malignant white blood cell disorders, there is an entity called persistent polyclonal B-cell lymphocytosis. And this is where the absolute number of B lymphocytes is increased, usually around 3 to 15, so not markedly increased like we see with indolent CLL or SLL, but the difference here is these lymphocytes are non-clonal, they are polyclonal, so they've got a normal capital lambda ratio. But there is a specific clinical phenotype associated with persistent polyclonal B-cell lymphocytosis. Sorry, excuse me, can we just make sure that everyone is muted? There is a bit of background noise. Everyone can just mute themselves. Right, so the clinical phenotype is usually females of more or less 40 years old. 95% of these patients are smokers. So that is why it also made it onto the talk today. And 90% have an HLA-DR7 genotype. Splenomegaly is a common finding in these patients, and lymphadenopathy has also been described. So in the lab, like I said, it's not a sky-high lymphocyte count. It probably won't impress most of us, between 3 and 15, but it is persistent, and that's usually the giveaway or telltale sign. But where one should really think of it as hematologists, the peripheral smear often shows binucleated lymphocytes. And I'll show you a picture on the next slide. Bone marrow infiltration has been described often with an intrasinusoidal pattern. They can also have increased serum IgM. And just take note that if you do find rearrangement of the IgH heavy chain gene, this is an exclusion of polyclonal B lymphocytosis. What you can find, however, on cytogenetics is an extra isochromosome 3, and this has been considered to be very specific of persistent polyclonal B cell lymphocytosis. So what do you do with these patients? They are definitely not for treatment. They are just for careful follow-up. I would probably think that the follow-up interval should be 6 monthly and then yearly, but Jar can give his opinion here as well, because only a very small minority of these patients will go on to develop other indolent non-Hodgkin lymphomas. Here are the 2 pictures, and you can see that these are very characteristic lymphocytes with bilobed or multi-lobed or multinucleated cells. Right, moving on to platelets and coagulation in general. And I think here again, something that the general audience knows a lot about is we do know to associate smoking with increased risk of cardiovascular disease, specifically coronary artery disease and other arterial thrombosis. And this we've been taught since medical students. As far as the venous system and venous thrombosis goes, that's not as well eluded, but we'll get to that. So in arterial disease or coronary arterial disease, we know the pathophysiology has been very well defined, and all of it is basically as it relates to the development of arteriosclerosis, which is the plague that eventually gives the thrombus or the arterial occlusion. So there's vasomotor dysfunction, impaired vasodilation, there's an endothelial dysfunction, there's decreased synthesis of nitric oxide, there's activation or long-standing chronic activation of the endothelium, downregulation of coagulations, coagulation regulators, there's lipid modification, and there's this ongoing chronic inflammation. You've seen on the comparison of the full blood counts and the increased leukocytes, but also there's an established association with increased pro-inflammatory cytokines, and this is also shown in population-based studies that as smokers have a very high or higher baseline CRP, tumor necrosis factor alpha, etc. This is a very involved diagram explaining the pathogenesis of atherosclerosis or atherothrombotic diseases in smoking. But if I can just maybe diverge your attention here to what it is actually in smoke that causes the tissue dysfunction that we're discussing this afternoon. So first there's free radicals, there's activation of endogenous free radicals, and there's activation of neutrophils, monocytes, and platelets. And as we know, if you are able to pathogenically activate platelets, that's the beginning of the end as far as vascular disease goes. In turn, this will also lead to these activated cells releasing cytokines, which will then auto-activate more of these cells and recruit more of these cells. There's also, on a genomic level, activation of inflammatory genes, and this leads to, like I mentioned, vasomotor dysfunction, leukocyte and platelet activation, lipid changes, adhesion and inflammation molecules being upregulated, and then smooth muscle proliferation. So this, like I said, is very well described for the arterial system. But what about the venous system? So this very recent article says that smoking is a well-established risk factor for cancer, and cancer patients have a higher risk of VTE. So conflicting results have been reported on the association between smoking and the risk of VTE. So they looked at this in cancer patients, and when they removed cancer as a confounder, they actually did not find an increased risk of VTE in smokers. Conversely, this very recent publication, or not very recent, relatively recent publication, actually was titled "A Dual Pathogen for Arterial and Venous Thrombosis." And as you can see, listed smoking in the overlap circle as a dual risk factor for both venous and arterial thrombosis. So they definitely think it is a thing. And if we are not in agreement about something, or something is controversial, we usually go look at systematic reviews and meta-analyses. And I could only find two to this effect. The first one says the relationship between VT and smoking has clinical relevance with respect to individual screening, risk factor modification, and the primary or secondary prevention of VTE. However, they did not really find a statistically significant increased risk for VT because BMI appears to be the most confounding factor. For venous thrombi, this makes a lot of sense if you think about stasis. The second meta-analysis that I could find, they also here state that except the association of cigarette smoking with provoked VTE, which is potentially mediated through comorbid conditions such as cancer, CVD risk factors are not associated with increased VTE risks. So for these patients, smoking does not appear to be a thing. And higher systolic blood pressure, however, they did show was inversely associated with VTE. And then just in conclusion of this talk, I just wanted to prime you to the future and what is awaiting us as hematologists and clinicians treating patients, and especially the adolescent population who's bound to become our mainstay of patients in the very near future. There's obviously a huge interest in cigarette replacements. Some of these thought to be non-harmful or not as harmful as smoking, but I was able to find this one publication of the emerging cigarette alternatives and their effects on the hematological system, specifically hemostasis. And you can see some of the things I recognized: e-cigarettes, vapors, some of the things I've never heard of in my life. But as you can see, numerous publications stemming out of these new agents, if you will. And also the FDA and the CDC have also issued warnings on many of these alternatives to smoking, that they are not as harm-free as they seem. And that brings me to the end of my talk. And yeah, I'll take questions now if there are any.
Thank you, Larissa. That was really interesting and a very comprehensive overview. I just, if while people are thinking about questions, I'd just like to ask something. We've seen, like, for instance, with the cannabinoids, where synthetic THC and synthetic THC derivatives have been found to have some beneficial effects and have translated into the use of FDA-approved drugs like dronabinol and nabilone. Do you think you will ever get to a point where we could potentially get derivatives or compounds from tobacco products that could have some potential therapeutic application or some beneficial effect somewhere down the line, or is it just all bad?
Jaco, I tried to think of anything to that regard, but the problem with the main constituents of cigarettes and nicotine specifically is it's a habit forming drug, basically. So it would be very difficult to alter these into therapeutic platforms, I would think.
Yeah, that would make sense to me. Thank you. Any other questions for Larissa?
No questions from my side, Larissa. I thought it was an excellent overview and thought-provoking and funny at times. So, Jaco, from your side, anything more? So it then rests on me to thank the team from the University of the Free State for today's talk, and thank you for everybody of you for dialing in and being part. So, good afternoon.